prostate cancer. They just have normal age-related enlargement. However, you really can't determine just based on the symptoms whether you're dealing with prostate cancer or normal enlargement. So when men start experiencing those kind of symptoms, they need to talk to their doctor and share that information, and then their doctor can decide what sort of assessment or evaluation might be helpful at clarifying what's causing that.
Walk me through. So, if a man has these symptoms and they go to their doctor, what should that exam be like? What should that visit entail?
Well, what I'll say is that for most doctors, they're going to start with a rectal exam because of where the prostate sits. They're at the base of the bladder. By putting a finger in the man's bottom, they can actually reach up and touch the backside of the prostate gland. So by reaching in, feeling it, they can, one, determine whether or not it feels like that gland is enlarged, but two, they can feel whether the gland still feels of normal consistency, or if it has some irregularities, lumps and bumps, or hard areas that might be suggestive of cancer. So, a lot of men are reluctant to talk with their doctor about these symptoms, or they're frankly concerned about having a man put a finger in their bottom. And there are, unfortunately, some sort of sexual overtones for some men about this. It's just part of a normal physical exam, in the same way that, if a doctor is doing a pap smear or a pelvic exam on a woman, that is not a sexual activity. That is a normal part of the physical exam. So what I say to a lot of men is you need to get over yourself. When I'm doing a rectal exam on a man, I'm doing a medical procedure, no different than listening to their heart and lungs, and I'm not going to be asking them out on a date or sending them flowers the next day.
Right.
It is part of a normal physical exam, so they need to get past that concern. And then there also is a blood test. Now, what we started off talking about is symptoms, but for many men, they're going to have a conversation with their doctor starting usually in their 40s about doing screening tests looking for prostate cancer. And screening tests, you don't have to have symptoms. As a matter of fact, once you have symptoms, the tests are no longer considered screening. Now you're trying, as a physician, to make a diagnosis. Screening exams are tests that you do on people who don't have any signs or symptoms of the disease, but you do it in people that you know are at risk of that disease. So again, for women starting in their 40s, we start to do mammograms. We don't do mammograms because we feel any lumps in the breast or women are having any issues or problems. We do them because we know that women start running a risk of developing breast cancer in their 40s, and therefore we want to do these tests and try to find the disease early. In the same way, screening for prostate cancer is something that we initiate for men, or at least start talking about for men in their 40s, because that's when they start developing a higher risk of having prostate cancer. And screening exams for prostate cancer, the main one that men are familiar with is a blood test. And that test is called the PSA, or prostate-specific antigen blood test.
Now, earlier you had mentioned about having a digital rectal exam. I know some physicians are trying to get away from doing that and only using a blood test. But I think that the digital rectal exam is important.
Well, for men who have symptoms, it is absolutely essential. But for men who are just being screened, its value is a little more limited, at least when it comes to their primary care doctor. So if they're seeing their family doctor or seeing a general internist, to be honest, a lot of general internists and family doctors aren't really that skilled at doing the digital rectal exam, so they tend to miss some abnormalities, and then they also tend to overestimate how large glands are, et cetera. So we don't any longer require that men who are being screened for prostate cancer have both the blood test and the digital rectal exam. But if doctors are comfortable, they feel that their skill level is high enough, and the men are willing to have the test done, have the rectal exam done, then it's fine. It can be part of that. So then you're doing two tests. But if you're doing screening, you always have to do the blood test. The rectal exam is optional. The blood test is the main test that we use for screening.
And that's what I wanted to highlight. the difference because, you know, you still need to get screened. You still need to go to see your doctor on a yearly basis. And especially for African American men who they already don't like to go to the doctor, they really and truly need to make sure that they start their screenings even earlier. How old should a man be before they start the screenings, especially in African
Well,
Americans?
as you mentioned, African American men are at higher risk than other men in the U.S. of developing and dying from prostate cancer. Consequently, and they're at higher risk of developing the disease early in life. So it's our recommendation the doctors start talking to these men in their 40s about getting screened. Now, no organization, the American Cancer Society or any other organization, currently recommends that every man gets screened every year because prostate cancer screening is kind of complicated and there are some potential downsides to doing screening exams. So our recommendation is that doctors talk to their patients and explain that patient's individual risk. Okay, you're an African American man, your father had prostate cancer, therefore you're at higher risk. And so explain the risk and then talk to the man about the potential value of doing the blood test and or the potential rectal exam.
Mm-hmm. And
those conversations, again, should start among men in their 40s. And if men are going to get screened, African-American men should start at age 45 if they don't have a family history. If they have a family history, then they should start at age 40 getting screened.
Okay. You mentioned some downsides. One of the downsides is we create false positives, and we start doing more testing because of those false positives. Is that not correct?
Yeah, that is one of the major downsides. The PSA test is an okay test, and frankly, it's the best test that we have for prostate cancer. But more men who have a abnormal PSA level will ultimately be found not to have cancer after additional testing than those who have, particularly if it's a mild elevation. In general, a normal PSA level in the U.S. is considered to be less than 4 nanograms per milliliter, just less than 4. So if your PSA is under 4, you're at low risk of prostate cancer. If it's over 4, you're at high risk. That number 4, quite honestly, is not a real set-in-stone sort of number, and there are some organizations that really say if your level is higher than 2.5, then your risk of prostate cancer may be higher, especially if you're, for instance, a younger black man. But again, we don't have a hard value where we can say if it's higher than this, you have cancer. If it's lower, you don't have cancer. So that is one complicating factor. Now, the higher your PSA level, the more likely it is to be associated with cancer. So if your PSA is 4.1 or 4.2, there's a good risk that it is not cancer-related. If your PSA is 20, then most PSAs in that level are going to be associated with cancer diagnosis. So it's good to know what that number is. But you can only take so much reassurance from a lower PSA because maybe 20% of men who have PSAs who are diagnosed with prostate cancer have PSAs under that level of 4. So just because it's under 4 doesn't mean you have no risk of prostate cancer. It just means your risk is lower. And then, as you mentioned, once a man has an elevated PSA level, now they're headed down a track of a lot of additional testing and follow-up. For some doctors, they'll simply order another PSA in 3 months or 4 months to see whether the level's going up or down. But some doctors are going to send the man for what's called a biopsy, where a small needle is inserted into the prostate gland and multiple little samples of the gland are taken looking for cancer.
At this point, the man is usually with a urologist. Is that not correct?
Oh, yes. Once you get to the point, once your primary doctor finds an elevated PSA, now, again, depending on your doctor, he or she may just follow you up and have another blood test done. But if they feel you need more than that, they're going to refer you to a urologist, a specialist in the prostate and the urinary tract.
Hmm. Can we go through some of the causes of prostate cancer?
Well, the main risk factor for prostate cancer is life. And the older you are, the longer you live,
That's right.
the greater your risk of developing prostate cancer. The other risk factors are family history. So if you have a particularly father or brother, but even uncles and grandfathers who have prostate cancer, then you have elevated risk. Being black is also a risk factor, and it's not just black men in America, but as we've gathered more data from around the world, black men from the Caribbean, black men from most regions in Africa, all have higher risk of developing prostate cancer. There's been a lot of work done to try to determine whether there are some specific genes associated with race and ethnicity that would account for this, and so far there aren't any real clear answers about that. There also are some occupational exposures. There's some question about whether farm workers who dealt with certain kind of chemicals may have an increased risk. But again, the vast majority of cases of prostate cancer in the U.S. occur in men who are older, or those men who are black or have family history.
Does diet play a role?
There is not a lot of good evidence about diet as a risk factor for developing prostate cancer. There are some studies that suggest that, maybe a diet that's high in fats might contribute. Maybe a high calcium diet may contribute. So, a lot of milk or dairy products. But that evidence, I'd say, is relatively soft. Once a man is diagnosed with prostate cancer, however, we do know that how they respond to treatment and how well they do afterward can be impacted by diet. So and particularly by weight and physical activity. So if a man is diagnosed with prostate cancer and is obese and remains obese, then his risk of having that cancer spread or cause him greater problems is higher. In the same way. Physical activity. Also, if a man is very active, then he may lower his risk of the prostate cancer spreading or worsening. Now, again, lowering the risk doesn't mean he eliminates it. But what I would say is for men who have been diagnosed with prostate cancer, getting very serious about following a healthy diet, losing weight, and having a high level of physical activity can make you feel better, help your response to treatment.
Now, you mentioned obesity being an issue. Do we know why exactly that is? I know there have been some studies that are, looking at that. But do we?
Yeah, obesity. Know? Yeah, obesity actually turns out to be a risk factor for a lot of different kinds of cancers, and also a predictor of treatment response for a lot of different kinds of factors. And there, as you mentioned, there's a lot of research going on. One thing that we know is obesity actually triggers the development in the body of what are called inflammatory markers. So obesity is in some ways sort of like an infection. If you get an infection, your body tries to fight it off by developing these different inflammatory responses. That's why if you have, cut on your leg and it gets a little infected, it gets kind of red and puffy because that's your body fighting that off with these inflammatory markers. Well, similar kinds of inflammatory markers are developed in obese people and are at higher rates. And we now think that a lot of cancers are, at least in part, stimulated by this sort of chronic low level of inflammation. Obesity also impacts hormone levels and can cause shifts in hormones. And we do know that prostate cancer is, in part at least, a hormone-dependent tumor. Men produce higher levels of a hormone called testosterone. And, testosterone may be a stimulant and Obesity impacts both testosterone, the male hormone, and estrogen, female hormone levels in men and women. And that interaction may also be contributing to some of the cancer influences that we see.
I'm glad you have brought that up because I was going to also mention that obesity in the adipose tissues, it gets turned into estrogen, and that's what fuels a lot of these cancers. Tell me about, so we talked about diagnosis. What about treatment? So you have the diagnosis of prostate cancer. What do you do now?
Well, that's another reason that the whole prostate issue is complicated because not every man necessarily needs to be treated if prostate cancer is diagnosed. That's a relatively unique phenomenon. There are very few women, for instance, in whom we diagnose breast cancer and say, well, yes, you have cancer, but let's just watch it. On the other hand, because prostate cancer is in many instances a very slow-growing kind of disease, we know that if we treat every man with cancer, we're going to end up causing some harms for men who never would have experienced any harms from those cancers if we just left it alone. So there is a grading scale that we use to try to grade how aggressive a man's prostate cancer is. And so when that biopsy I talked about earlier is done, the doctors look at it under the microscope, and based on how it looks, they try to ascertain whether the cancer is likely to be a very aggressive kind of cancer that's going to grow fast and spread to other parts of the body, or if not, if it looks fairly close to normal kinds of prostate cells, then they may assign it a lower grade. Depending on what that grade is, they then will talk to the man about the need to have some sort of invasive kind of treatment right away. Or on the flip side, if the cancer looks like something that may grow very slowly, and they also have to look at the man's overall health status. If it is an older man, let's say a man in his late 70s, and he's got some heart disease or he's got some lung disease, things that are likely to shorten his lifespan, his doctor may feel that going through cancer treatment is not likely to benefit him, but actually is more likely to cause harm. So for those men who have that slow-growing kind of disease, we will sometimes encourage them to adopt what we call a active surveillance approach, which is we're not going to use any kind of surgery or medication or other treatment on this cancer. We're just going to watch it. We're going to continue to track your PSA levels over time. And there may be some other kinds of monitoring tests that we do, but we're not going to treat the cancer unless it seems to be starting to show evidence that it's growing or spreading. On the other hand, for younger men or men who don't have other health issues, and particularly for men who have a higher score, the score, I'm sorry, I didn't mention, it's called the Gleason score. And a Gleason score of, let's say, 2 or 3, that's a low Gleason score, and that's associated with cancers that don't look like they're going to grow or spread very rapidly. A high Gleason score is a cancer 7, 8, 9. If you have a Gleason at that higher level, then most doctors are going to recommend that you have some form of treatment. And then with regard to treatment, there are actually a number of different options for active treatment, but the main categories are either surgery or radiation treatment. And then within each of those categories, there are different surgical approaches and a variety of different radiation treatment approaches.
So say, for instance, a man does nothing. About how long from the time of diagnosis to, say, the end of life, how long does this cancer take to grow? I know in cervical cancer, it takes about 10 to 15 years if you don't do anything with that. And I kind of liken prostate to cervical. We call them slow-growing tumors, so to speak.
Yeah, and it varies in part from man to man. It varies by that Gleason score. So again, men with a Gleason score of 2 or 3, their cancers are likely to take a long period of time, 7, 8, 10 years. And if you're talking about using that watchful waiting approach in men who are older, in their 70s and 80s, in most instances, those men are going to end up dying
Yeah,
from
they'll
some
die
other
from something
cause
else.
or
Hmm.
before their cancer ever causes them any harm. And that's a big part of why we choose the watchful waiting, because we don't want to expose those men to the potential harms and risk and just the challenges, the physical challenges of undergoing prostate cancer treatment when they're going to end up dying of their heart disease or having a stroke or some other kind of issue. Um, but it is, we don't have any solid predictor, I would say, outside of the Gleason score. And the Gleason score, like the PSA level, is a somewhat inexact tool. There's a lot of work going on trying to come up with better ways to assess which cancers need treatment versus those that may do well without treatment. For instance, there are a number of places now where they're doing MRI scans, actual sophisticated X-ray studies to look at the tumor and try to use not just the Gleason score, but how that tumor looks on X-ray to determine whether this is the kind of tumor that's likely to grow and spread. And there are some early, very promising kind of results, but that I don't think is a standard part of every man's treatment yet.
Yeah, I have an uncle who had prostate cancer, and I know that that was not part of his treatment was an MRI. So I don't think that that's as standard as hopefully it will be in the years to come. Tell me this: prevention. Is there any way to prevent this?
Unfortunately, again, because we don't have a lot of knowledge about the underlying causes, and because the risk factors are things, I mean, we can't really control our age or our race or our family history. The best approach is simply to be knowledgeable, to know, for instance, know about your family history. It is absolutely shocking how many men have no idea what kind of health issues their relatives have had. And so knowing, what health issues are common in your family, and knowing in particular whether or not there's prostate cancer in your family is important, because that's something you need to keep in mind when your doctor's talking to you about whether or not you want to get screened. Maintaining a healthy lifestyle is, we don't know for sure that it protects against prostate cancer. But as I mentioned, if you are diagnosed with prostate cancer, you're going to do a lot better if you're not overweight and if you're physically active. And there may be a protective element, but even if it doesn't protect against prostate cancer, it protects against other diseases like colon and rectal cancer, and protects against heart disease and diabetes and a wealth of other things. So maintaining a healthy lifestyle, avoiding tobacco. I didn't specifically mention tobacco, and the association between tobacco and prostate cancer is not as strong as it is for some other cancers, but there may be a link there, and you're certainly not going to harm yourself by being tobacco free. So really just maintaining a healthy lifestyle and being aware and making a decision early in life as to whether or not you want to be screened for prostate cancer. And then if you decide to get screened, then you need to stick with it, because you can't have just one screening test at age 45 and it's okay, so then you ignore it. You need to then enter into screening at least every year or every other year, depending on what your PSA level is, because it's potentially going to change over time.
You mentioned tobacco, and I know we talk about getting people to stop smoking. What smoking actually does is it changes the genetic makeup, does it not? It actually can cause mutations, and some of those mutations can then translate into cancers, correct?
Yes, that's one way that tobacco does harm. Tobacco also, for instance, at least in the lung or even in the gastrointestinal tract, can also stimulate some of those inflammatory markers that we were talking about earlier, and they actually cause direct inflammation.
So here's another
So
reason why to
there are a
stop
lot of different
smoking.
ways it's harmful.
Yeah, stop smoking. Um, let's talk about insurance coverage. You know how insurance covers a yearly pap smear and mammogram for women. Does insurance cover prostate screening exams?
Actually, it does. For most insurance plans, it will, and for Medicare, it is covered as well. As part of the Affordable Care Act, one of the things that is required is that insurance plans cover any sort of screening that is recommended by this federal agency called the U.S. Preventive Services Task Force. So colorectal cancer screening, breast cancer screening, those are all recommended by the task force. Now, the task force is just like other organizations, and it does not explicitly recommend that all men be screened. It recommends that all men have a conversation with their doctor about whether or not to be screened for prostate cancer. However, to this point, insurers have continued to cover prostate cancer screening if men and their doctors decide that that's something that they want to do. Once a man is diagnosed with prostate cancer, then again, the vast majority of insurers are going to cover whatever treatments are necessary, be it a surgery or radiation or the active surveillance I talked about earlier.
That's good information. What resources are out there for men as far as learning about prostate cancer and if they actually get a diagnosis? Are there any support groups for them?
Well, the American Cancer Society has created a lot of different resources around prostate cancer. We have resources specifically for men who are thinking about whether or not to get screened that give some of the information about the benefits and the potential harms of getting screened and of treatment. We also have tools for men who have been diagnosed with prostate cancer that talk about the different kinds of treatment options and what the potential benefits and downsides of treatment are. And any and all of our resources can be found at cancer.org, so www.cancer.org. We also have an 800 number, 1-800-ACS-2345, and that number is staffed by a what we call a cancer information specialist. There's somebody who will answer that line 24 hours a day, 7 days a week, and can provide you with some information about prostate cancer or any other kind of cancer issues, can send you information, and can also link you to resources if you are, for instance, are a cancer patient. You're having challenges with finding a treatment resource, or women who, for instance, have had cancer treatment and hair loss. We have programs for wigs. We have support group services, both in person and virtual. So you can find information about what we have to offer at 800 ACS 2345.
All right. Tell me about your work with American Cancer Society and the research that you do.
Well, as you mentioned, my title is Vice President of Cancer Control Intervention. And so basically my role, I work in what's called our Prevention and Early Detection Department. So I have just the incredible good fortune to work with an army of cancer prevention specialists around the country. And we work a lot with primary care physicians and practices, trying to help them understand the latest information about cancer screening tests, what works, what doesn't, how to encourage their patients to get screened for different kinds of cancers. So we have a lot of different tools, educational tools for their patients, and practice tools that we use. We also, there are certain cancers that we can actually prevent. So I've mentioned colorectal cancer a couple of times, and when people think about getting screened for colorectal cancer, most people think immediately of a colonoscopy. Well, colonoscopy is a very effective tool and it's a good tool, but there are other tests. So if you don't have access to or you don't want to have a colonoscopy, there are other tests available. So we work with doctors to try to make sure they're offering those options. But colorectal cancer screening is one of those where we can prevent cancer, because when we do the screening test, we actually can find something called a polyp before it turns into cancer and prevent cancer from occurring. Another way that we can prevent cancer is through a vaccination. Many people may have heard of the HPV vaccination. That series of immunizations is something that is now recommended around the world for children starting between the ages of 9 and 11. And it prevents infection with something called the human papillomavirus, or HPV. And what we've learned over time is that HPV is the main cause for cervical cancer in the U.S. and around the world. So cancer of the cervix in women is largely an infectious disease. And by starting children with that HPV vaccination early in life, we can eliminate most risk of cervical cancer. But not only that, there are 9 cancers that all are associated with the HPV virus. So HPV vaccination is recommended for both boys and girls. And one of the areas in my portfolio is our team that works on HPV vaccination and works with primary care practices and health plans and health systems to try to increase the use of that vaccine. Now, if somebody had told you when you were in medical school that we were going to have a vaccine and all you had to do was get 2 shots for your children and you could help prevent 9 different kinds of cancer, wouldn't you think everybody would be lining up to get that shot?
Absolutely. But they're not.
Less than, only about half of children in the U.S. are currently up to date with this vaccine that helps prevent cancer.
Why?
So, we've made a lot of progress, but we have a lot of work to do. A lot of parents simply aren't aware of it. They may have heard that there is such a thing as HPV vaccine, but they don't know that we're talking about a cancer prevention vaccine. A lot of doctors treat this vaccine differently. When your child goes in and it's time for them to get their tetanus immunization, they don't ask the parents, well, would you like a tetanus shot? They just do it. For some reason, they treat the HPV vaccine differently. And then there are some myths about it. There is the perception that because HPV is, at least in part, a sexually transmitted disease, that, well, my 9-year-old's not having sex. The purpose of giving them the vaccine is that your 9-year-old, if they grow up and be a normal human being, they're going to have sex someday. Giving them the vaccine before they begin sexual activity is protecting them against any future activities. And you don't have to sleep around to get HPV. The vast majority of adults in the U.S. have had an HPV infection, probably better than 90% of us at some point or another. It only takes you having a sexual encounter with one person, and that one person having had a sexual encounter with one other person who happened to be carrying that virus for it to get spread to you. So it's not a marker of poor morals or any, but there are, unfortunately, a lot of judgments associated with HPV that just don't belong there, and people use those as reasons not to vaccinate their children. Again, the idea that I have a vaccine that can prevent my child from getting cancer and I'm not using it, I just don't get it.
Yeah, I have to agree with that. That reminds me of a commercial that I see about the HPV vaccine, and it's children that are basically saying to their parents, if there was a vaccine available and it could prevent me from getting cancer, why did you not give it to me?
And those are based on real stories. Unfortunately, I've met a number of adults who experienced an HPV-related cancer during early adulthood. I mean, we're talking about people often being diagnosed with cancer in their 20s and 30s that could have been prevented with the vaccine. And they're a strong part of the work that we do with HPV vaccination, because even though they're surviving, they talk about the horrors of the treatment, how difficult it is to be treated for cancer, especially when you're in your 20s and 30s, the prime of your life. Cancer is not something on your agenda. So the ability to prevent those stories in the future is a big part of why we do the work that we do.
You mentioned 9 cancers that are linked to HPV. Can you go through those quickly?
Certainly, there is cervical cancer, which is the first one that everyone thinks of, but there also is cancer of the vulva, the lips of the female vagina. There is now I feel like I got a test here. There is
no
there's
test.
there's anal cancer. I talked about colon and rectal cancer. Those are actually different than anal cancer. There is no association known between HPV and colon cancer or rectal cancer. The cancer of the anus, the lower portion of the colon, right before where stool exits the body, cancer of the anus is strongly associated with HPV. In men, penile cancers, cancer of the penis is a HPV risk. But actually the most common HPV-related cancer in men is cancer of what's called the oropharynx. So basically mouth and throat cancers are very common in men. And that's because of both the penile, anal, and the oropharyngeal cancer in particular. That's why the vaccine is recommended for boys as well as girls, in addition to the fact that boys can spread. So if we're only vaccinating girls, then boys are still potentially going to get infected and then spread it to some of their partners. So it's recommended for both boys and girls.
I think you did good
I don't think I gave you all 9. I gave you most of them.
I think you did good.
Okay.
So, in my readings, I always read, and I came across a study that the U.S. is doing about prostate, lung, colorectal, and ovarian cancer screening trial. Can you go through that?
Yes, that was actually a trial that was started, I believe, back in the late 1980s or maybe early 1990s, trying to determine whether screening for these different kinds of cancers was effective, whether it was something that would actually help save lives. Because, as I mentioned earlier, prostate cancer screening is a little controversial, and some men are helped, but other men are harmed. In the same way, lung cancer screening, screening for the ovary, again, there may be some benefit, but there are harms. Colorectal, actually, I think the evidence is pretty clear around that one at this point. But when that study was started, it wasn't quite so clear that colorectal cancer screening is as impactful as it's proven to be. The prostate cancer arm of that study, the PLCO trial, actually came out and said it wasn't clear that prostate cancer screening was beneficial for men. The problem is a couple of problems with the trial in general, and this is both with regard to prostate cancer screening, lung cancer, and ovarian cancer screening, and colorectal. When they started doing that study, there were only certain kinds of tests available. So they did do PSA blood testing for prostate cancer, but for lung cancer screening, they started off just doing plain chest x-rays, and chest x-rays aren't particularly effective for lung cancer screening. For colorectal, they started doing a test called the flexible sigmoidoscopy, which over time has actually proven to be beneficial. But we've had major changes, and now colonoscopy is much more widely available and widely used. And for ovarian cancer, they used a blood test. But since that time, there have been a variety of other tests. So unfortunately, the results of the trial didn't really keep up with the advances in technology. So in some instances, they were testing tests that really are no longer used for those purposes. So by the time we got answers, we had new tests available, so it in some ways made the trial not as helpful. The other problem with particularly the prostate cancer arm of that study Two things. One, I mentioned that African American men are much more likely to be diagnosed with prostate cancer and die from it in the U.S. But when they were putting the trial together, they had a lot of difficulty attracting a significant number of African American men. So what you can do, you can look at the study and say, well, this shows that in white men in the general population, screening for prostate cancer with PSA may not be very helpful, but it's a big leap to then say, and because it doesn't help in white men, it also doesn't help in black men. Well, black men are different. Their risks are different. So we really don't know how well PSA performs in black men. And another confusing element is when they first started doing the trial, there wasn't a lot of use of PSA in the general population. But over time, more and more doctors started using the PSA blood test. So they ended up in a situation where many of the men who were presumed to be not getting screened in the PSO trial actually were being screened by their doctors, being dealt with differently. So it's sort of like if you were doing a study of aspirin and you gave one group aspirin and the other group you said, don't take aspirin. And then the other group went ahead and took aspirin anyway. You can't really compare the outcomes when both groups are getting that.
I agree with that. You bring up ovarian cancer, and ovarian cancer is the second most common type of female GYN cancers, but it's also the deadliest of them. And unfortunately, there's no good tests, as you talked about, for ovarian cancer. We kind of have to go based upon a woman's symptoms, and even those symptoms can blur the lines because a lot of those symptoms can be mistaken for something that's not serious. And so what that does is it causes women to think, oh, there's nothing wrong with me, yet there actually is. So can we talk about ovarian cancer for just a little bit? I know that's not necessarily in your line of expertise, but because you're familiar with the cancer research, maybe you can play along with me.
Certainly. Well, yeah, as you already mentioned, ovarian cancer is actually quite common in women. It is one of the relatively small cancers that doesn't discriminate in the same way that other cancers do. That is, black women don't seem to have a strikingly higher chance of developing or dying from it, but they still do. I think about 1,300 black women in the U.S. die from ovarian cancer each year. And as you already mentioned, we don't have a good test for it. The blood test that was tested in the PLCO trial turned out not to be especially beneficial. There have been other tests being developed and studied along the way, but so far we don't have any good blood tests. There also have been attempts to look at ultrasound or X-ray exams to try to determine whether those can be used for screening tests, but so far nothing has really proven to be highly useful to do for all women who aren't having any symptoms of disease. And then the symptoms, as you mentioned also, are vague. It's things like abdominal bloating or changes in menstrual periods if women are still young enough to be having periods, changes in bowel habits, but all sort of vague symptoms that quite honestly are not uncommon in middle-aged women, which is where we see a lot of ovarian cancer, or in older women. And consequently, and sadly, most ovarian cancers therefore end up being diagnosed with in much later stages of disease after the tumor has grown and oftentimes spread beyond the ovary to other parts of the body, which means it's a lot harder to treat. And therefore, women are more likely to die of ovarian cancer because it's being diagnosed later and we're not able to treat it as effectively.
Yeah, the later that you get diagnosed, it's about an 18% survival for stage 4 ovarian cancer. So that's a pretty low survival rate. Very rarely are women diagnosed in early stages. I have actually diagnosed several younger women when I've gone into surgery for what we thought was an ovarian cyst, and when we get inside, we get surprised. And it turns out to be ovarian cancer. That's really the only time that I've been able to catch cancers at an early stage, and those patients have done very well and generally can go on leading their productive lives. And as you said, I know that there was a study in the United Kingdom that was actually done on cancer, ovarian cancer screenings, and it actually showed that there was more harm than good that came with these screening tools, which they used the blood test as well as the ultrasound. So, you know, as physicians, we've taken an oath to first do no harm. So sometimes we can, if we try to test too much, we can start causing more harm than good in the patients.
Yes, that which is the same issue with prostate cancer screening. Only it's even worse with ovarian. At least PSA blood test does have some chance to find the cancers early, but the tests we have available with ovarian cancer have a much lower likelihood of finding that early stage disease.
And even if we do exams, you know, we have women that come in to have their pap smears, and we also will do a pelvic exam. But unless the tumor in the ovary or in the abdomen is rather large, it really is difficult to be able to palpate, or what we call feel, any of the tumors until it's too late. Generally, we can pick up on it if we, you know, start trying to look for causes of why you're having bloating or why you're having abdominal pain, why you're having changes in your cycles. That's generally when we can pick up on it. But by then, it's pretty much at the later stages, so to speak.
Yes. Yeah. Now, I mean, there are some risk factors that we know for ovarian cancer that, you know, women, I think, should at least be aware of. And some of those, there actually is a pretty strong genetic component in women who have a family history of breast cancer, and particularly if they have a gene-related kind of breast cancer, what's called BRCA1 or BRCA2 genetic changes. Those women are at higher risk of being diagnosed with ovarian cancer. There also are women who have a family history of colorectal cancer, and there's a syndrome, a genetic syndrome called Lynch syndrome. That means that you have a lot of people in your family who have colon cancer diagnosed at earlier stages or have colon polyps. Well, ovarian cancer is also more common in those families. So knowing your family history, as I talked about earlier, is one key thing that you can do to recognize whether or not you may be at higher risk of being diagnosed with ovarian cancer. So talk with your family and find out about your family history overall and cancer family history in particular, and then share that information with your doctor.
I really think if, you know, people don't get anything else out of this, is know your family history. That is so important because I don't know about you, Dr. Brooks, but I know in my family, people don't really talk about their medical problems. And so you don't know what your grandmother maybe had or what an uncle had, but that all plays a role in your care and how we can diagnose and treat things.
Yeah, and I encourage, I mean, I know in particular in the African-American community, we're really big on family reunions. And, you know, every summer, people are getting together from all over the country, or at least from a number of different states, to gather and fellowship and enjoy one another's company. Well, during that time, let's create some family trees. Let's find out who our family is, where they came from, but also what took them away from here and what kind of health issues they had along the way, so that we know that information and we can share that information with our children and, over time create successively healthier generations.
Yes, one of my cousins and I are actually doing our family tree on my dad's side of the family. And that's one of the things when we have a death in the family, we try to make sure we find out what happened. We also go back and pull the death certificates from people because sometimes it'll have it on there what the cause of death was, and that really, helps because we found a lot out in our own family that we didn't know about. So it definitely helps me to be able to relay that to my physicians as well, because yes, I'm a physician, but I'm also a patient as well. Dr. Brooks, why do you think ovarian cancer and prostate cancers don't get the recognition, say, like a breast or a lung cancer does?
Um, well, one, ovarian cancer, compared to the overall numbers, is much less common than either prostate or lung cancer. Lung cancer, we're looking at more than 200,000 cases a year in the U.S. Prostate cancer actually is pretty common in men, about over 160,000 cases. But most men who are diagnosed with prostate cancer actually don't die of prostate cancer. They end up dying of something else. Because as I mentioned, and oftentimes it's in older men. I think the fact that we don't have really good screening tests for either of these cancers also is something that works against them. And again, we know more about prostate cancer, and men hear more about prostate cancer than women do about ovarian cancer, because we at least do have an imperfect screening test for prostate cancer, and we've got really nothing for ovarian cancer. A part of it also is what you just mentioned, and that is people don't talk. They don't share information with their friends, with their families. I spoke to an individual not too long ago who did not know that her father had colorectal cancer until he was in the hospital, literally on his deathbed. Oh, and wow. He had been fighting this disease for a couple of years. Now, that is extraordinarily important, not just from the standpoint of her being able to deal with her emotions, but also because she, as a child of someone with colon cancer, was at higher risk. She didn't know about it, and she ended up being diagnosed with colon cancer shortly after her father died.
Oh, wow.
If her father had shared that news with her earlier, she might have been spared. Now, she's still, fortunately, doing well. She was caught pretty early, but that was a cancer that may not have needed to occur. But her own dad didn't share that information with her. So we have to do a better job about making sure that everybody in our family knows what is going on with our health.
Yes, please do not keep your health a secret. We need to know. And as you said, it's not only important from a doctor's standpoint, it's also very important, from a child of, aunt of, anybody in the family. So,
Yes.
I just can't thank you enough, Dr. Brooks, for being on the show and highlighting, ovarian and prostate cancers. And I think definitely we need more discussion on these cancers. Just because September is coming to a close doesn't mean that we can't continue to talk about it. Can you give me the resources again for the listeners so that they can go on to ACS's website as well as
yes,
the call?
It's www.cancer.org will take you to the main page of the American Cancer Society site. And if you just type in on the box, ovarian cancer, prostate cancer, whatever it is you're interested in, or call our 800 number, 800 ACS 2345, and you can speak live with one of our cancer information specialists, and they will tell you where you can find more information. They'll send you out information. They'll provide. There are tremendous resources, and frankly, an underused resource. I think in particular, minorities aren't aware of this free resource, and we should be taking advantage of it in much larger numbers.
It is free. Please use it. Say it one more time, Dr. Brooks.
1-800-ACS-2345.
Well, our time has come to an end. Unfortunately, I have enjoyed our conversation. And once again, I thank my guest, Dr. Dorado Brooks from the American Cancer Society, for taking time out of his schedule to call in to us. He's actually traveling. Usually he is in Atlanta, but he's traveling. So thank you so very much for doing that. I want to leave with a word of the week. This is taken from Proverbs chapter 12, verse 18. The words of the reckless pierce like swords, but the tongue of the wise brings healing. You've been listening to Health Tips with the Nation's Bedside Doctor, Dr. Tami Prince. I will see you next week. Thank you.